We invest millions of dollars into suicide stigma research, trying to understand why so many people suffer in silence. But we are working with a significant blind spot, because as a field, we haven't reached a consensus on what we are actually measuring. Much of the current literature relies on the assumption that suicide stigma is a subtype of general mental illness stigma, essentially the same phenomenon, just more severe. Standard stereotypes for general mental illness typically center on behavioral unpredictability or cognitive incompetence. The public assumes the individual is erratic or unable to manage their own life. When we apply these generic assumptions to suicidal individuals, we mask the specific nature of their suffering. Suicide stigma is rooted in a specific history of religious and legal persecution, where the act was explicitly prosecuted as a moral transgression against the state and the divine. This side-by-side comparison shows the shift in traits. While general mental health stigma focuses on incompetence, suicide stigma is characterized by a unique moral condemnation. Suicidal individuals are frequently branded as selfish, cowardly, or sinful. This scoping review maps the exact process of how that specific societal pressure transforms into individual psychological harm. Utilizing generic mental health surveys to measure this moral condemnation risks capturing the wrong phenomenon, leading to data that may not reflect the patient's actual barriers to recovery. To understand how this works, we have to view stigma internalization not as a single event, but as a sequential timeline. The timeline begins with public stigma. Here, society projects a negative moral stereotype toward a target group. This leads to step 2, perceived stigma. This is the awareness stage, where the individual recognizes that society holds these hostile views against them. This awareness causes intense stress and leads many to conceal their history. However, simply recognizing a societal prejudice does not mean the individual agrees with it. Recognizing a hostile environment is a survival mechanism, which is conceptually distinct from believing the hostile message is true. There is a significant disconnect here between theory and measurement. Researchers routinely combine the act of perceiving public stigma with the act of internalizing it, treating the two stages as one. In psychometrics, this is a violation of construct validity. When a survey mixes environmental awareness with deep psychological absorption, the resulting data is mathematically polluted. This measurement error means that surveys often mistake a patient's valid fear of a hostile environment for a collapsed self-concept. This creates a mediational bypass. By blurring these two stages, it becomes impossible to determine the true cause of a patient's distress. Because of this measurement disconnect, clinicians are often blind to which stage of the psychological cascade a patient is actually experiencing. The final stage of the timeline is self-stigma, or absorption. This is the threshold where the individual actively agrees with the public prejudice. At this point, the societal deficit is applied directly to the core identity. The individual concludes they are fundamentally broken or unworthy of life. This internal collapse leads to the help negation effect. This is a devastating clinical outcome where the patient actively refuses available, life-saving help because they believe they don't deserve it. If our measurement tools continue to conflate environmental awareness with this internal absorption, we miss the very patients who are rejecting help due to self-stigma. Clarifying this distinction is vital. Failing to separate awareness from true internalization skews our understanding of self-stigma rates and obscures the reasons people refuse help. Standardizing this terminology is a necessary prerequisite for accurate clinical triage. Establishing a clear lexicon allows us to design interventions that address internal shame, ensuring clinical resources aren't misdirected toward broad societal normalization. These strict conceptual boundaries are the first step toward building accurate tools, targeting the correct psychological wounds, and saving lives.